All right, guys, so let's go ahead and get started. Just want to introduce myself. I'm Jeff Thiboutot. I'm one of the chairs of the Interventional Pulmonary Working Group. We're one of the working groups out of the Thoracic Oncology Assembly through ATS. We put on a couple of these webinars throughout the year. So this one, we have kind of an esteemed panel put together to talk about cryobiopsy today. What we're going to be focusing on are really the expanded uses of cryobiopsy, uses outside of specifically ILD. So this is going to be in our lung nodule population. We talk about mediastinal cryobiopsy and in the lung transplant population as well. So the format for today is we're going to have two short, brief introductory talks. They'll probably be about 15 or 20 minutes or so, and then we'll open it up for a panel discussion at the end. I do have some prepared talks, but some prepared questions, I'm sorry, but I'm really hoping that this to be interactive. So please, we'll be monitoring the chat. Go ahead and put any questions that you have in the chat and we'll get them answered for you. So with that, I'd like to go ahead and just introduce everybody briefly before we get started with presentations. Up first, I'd like to introduce Dr. Felix Herth. He's from the Thorax Clinic in Heidelberg, Germany. He's an interventional pulmonologist by trade. Next, I'd like to introduce Dr. Lucy Jager. She is a pathologist at Northwestern University. Also on the panel today is Fabien Maldonado from Vanderbilt University, interventional pulmonologist. Also is Momen Wahidi. Momen is from Northwestern University, also an interventional pulmonologist. We're very grateful to have Dr. Budev, Dr. Marie Budev from Cleveland Clinic. She is the director of their lung transplant program there. We are going to have presentations and talks from Dr. Christopher Kapp. He is an interventional pulmonologist at Northwestern as well. And also a talk from Dr. Jamie Roswell. She is a pulmonary critical care fellow at Northwestern as well. So hopefully I didn't miss anybody there. I think I got everyone. So with that, I think I will kick it over to Jamie to get started on her presentation.
All right, thanks, Jeff. Morning, everyone. So I'll be kind of giving us a brief state of the evidence talk for peripheral cryobiopsy, and specifically talking about lung transplant and peripheral pulmonary nodules, as Jeff mentioned. Before we get into all that, though, we'll start with just a visualization of the tools that we're going to be talking about today. And you can see here at the bottom of the screen, this is our kind of classic 2.0 millimeter forceps. Really has not changed much over the years. And then our two cryoprobes of interest, the 1.9 millimeter probe, which is an earlier version, and then the newer 1.1 millimeter sheath cryoprobe, which has really become the tool of choice for peripheral cryobiopsy in most instances. Go on to the next slide, Chris. So why are we even talking about this technology, right? What does it offer in comparison to our usual standard forceps biopsy? And the answer really lies in the quality of the tissue samples that the cryoprobe is able to produce. So picture really worth 1,000 words here. You can clearly see the cryobiopsy sample here on the left side of the screen, much larger tissue piece. You can see this nicely preserved architecture, open alveoli, really more histopathologically accessible for our friendly pathologists who are helping to nail these diagnoses for us, as compared to the forceps biopsy specimen, much smaller and lots of crush artifact, not seeing too many open alveoli, and also the presence of pretty significant hemorrhage. So this is just another kind of pictorial example of that. So this is our usual kind of 10 specimen forceps biopsies that we get some during our cases, and really can see the areas of hemorrhage and crush artifact abound kind of throughout that. Whereas compared to the cryobiopsy with only 4 specimens taken, we're really increasing our tissue yield here. So the next kind of logical question becomes, how safe is this technology, and what complications can we expect as we use this more and more? And when we look at early safety data from the larger cryoprobes like the 1.9 and 2.4 millimeters, we're certainly seeing an increase in rate of complications compared to the forceps biopsy. And specifically in these two studies published back in 2018, you'll notice that there's a 2-fold increase in the rate of pneumothorax and a 5-fold increase in the rates of bleeding. You can see on the right side of the screen, though, and I think very importantly, the procedural mortality, even with an increased rate of complication, is quite similar to the forceps biopsy. It still remains well below that of our surgical lung biopsy. So this is why, cryobiopsy traditionally has been reserved for the diagnosis of ILD, and at first not widely adopted for other indications. So this is just a slide kind of demonstrating that traditional technique with the larger cryoprobes. So traditionally this is performed with rigid bronchoscopy. You position your rigid scope with your deflated Fogarty balloon ready to deploy in the event of any bleeding. And you navigate your flexible scope out into the airway, extend your cryoprobe, engage that cryoprobe, and then you're pulling the flexible scope and the cryoprobe in block out of the rigid scope to get your tissue piece. And once that flexible probe is out, inflating the Fogarty balloon to prevent any bleeding. So kind of a clunky procedure, right? Requiring the use of rigid bronchoscopy, requires that you have an operator with the technical experience to really do this safely. And there was certainly a need for us to kind of adapt this tool to make it more user-friendly, and with the goal of creating a safer procedure while not compromising our diagnostic yield. And so we have the rise of the 1.1 millimeter cryoprobe. So this tool has really kind of changed the game. Works well in the working channel of a flexible scope, does not require rigid bronchoscopy, allows you to keep that flexible scope into the airway, and once you have your tissue specimen, simply removing the cryoprobe from the working channel. And this was an early study published in 2016, looking at the quality of tissue samples produced by this 1.1 millimeter probe. And you can see here, in terms of histological accessibility, the sheathed cryoprobe, or the 1.1 millimeter, performs quite similarly to the larger, more traditional probes used. And both of these much more or much higher yield compared to forceps biopsy. So this really paved the way for the first phase 1 safety trial that was published in 2022, known as Frostbite 1. So this was a total of 50 patients with the primary outcome being the rate of pneumothorax requiring intervention, or grade 3 bleeding requiring a bronchial blocker. And you can see here, our squares are a little off here, but an incidence of 0 for both of those occurrences. So this really opened the door for a number of clinical studies comparing that 1.1 millimeter probe to transbronchial biopsy in different disease states. So we'll kind of talk about 2 of those now. Okay, so uses in lung transplant. So as we all know, outcomes after lung transplant really do lag behind that of other solid organs, and median survival is really only about 6 years in this population. And a large driver of that morbidity and mortality after transplant is what we know of as CLAD, or chronic lung allograft dysfunction. And 2 really important risk factors for the development of CLAD are acute cellular rejection and lymphocytic bronchiolitis. And this really is a common condition, with over 50% of patients developing CLAD within 5 years of transplant. So an important point here, CLAD's really difficult to manage. There's no cure. So early detection of rejection is absolutely crucial in this population. And that kind of brings us into the role of the regular surveillance bronchoscopy. That really is the standard for our post-lung transplant patients, and viewed as kind of the gold standard for detecting early rejection. And historically, we've been using the forceps biopsy for this, but its sensitivity has really been shown to be quite variable for detecting rejection, and a lot of that related to those factors we saw in the representative pathology slides, that crush artifact and areas of hemorrhage. And additionally, our pathologic interpretation of these forceps biopsies has been shown to be quite inconsistent. So there really existed a need for better tissue specimens. So in 2013, we have our first pilot safety study of the use of the, in this case, the 1.9 millimeter cryoprobe in the lung transplant population. So this was a prospective observational study of 21 procedures between 2011 and 2012, and showed pretty promising results, or safety results, with only one pneumothorax and no severe bleeding. So from here, there have been a handful of other studies in the subsequent years that have reported on both the safety as well as the diagnostic yield compared to forceps biopsies. And as you can see in this kind of sampling of studies, these are generally the larger cryoprobes being used, mostly in these studies, the 2.4 and the 1.9. And the findings are somewhat variable as the procedural characteristics were in terms of things like number of samples taken. And most complications we can see here are mostly in the 2 to 5 range, although there are some higher rates of bleeding and pneumothorax. You can see in some of these, even one reported as high as 22% rate of moderate bleeding. But across the board, we're seeing increased size of tissue samples. We're seeing a higher percentage of alveolated tissues, and a signal that we are getting higher diagnostic rates for acute cellular rejection, lymphocytic bronchiolitis, and a fewer number of non-diagnostic procedures. So this was a nice meta-analysis published within the last year that looked into the differences in rates of detection of acute cellular rejection and chronic rejection with the cryobiopsy. We have to acknowledge this fairly low quality evidence, mostly from observational studies. There was one RCT in this group, and all of these did utilize the older version of the cryoprobe. But we are seeing higher rates with cryobiopsy, particularly for the diagnosis of chronic rejection. Pretty significant difference there. Okay, so that rounds out our lung transplant. So we'll move on and talk about some peripheral pulmonary nodules. So the logic for the application of cryobiopsy in this particular instance is pretty intuitive, right? Larger sample sizes, preserved architecture, higher chance of making a diagnosis. So this was the first safety study for the cryoprobe being used in peripheral pulmonary nodules, published in 2021. So this was a large multi-center observational retrospective cohort study, just over 1,000 patients. And all of these procedures, again, were done with the larger cryoprobes and via rigid bronchoscopy. Safety data pretty reassuring here, bleeding 18% of the time, but of those only 3.5 met clinical significance, and the pneumothorax rate just over 6%, with most of these requiring tube thoracostomy. Diagnostic yield, extremely promising, 91%. And of those that did have a non-diagnostic procedure that went on to a second procedure, a pretty significant percentage of those did ultimately end up with a diagnosis of malignancy. So this was a nice study published in 2023 from a group in Korea, and this specifically looked at the use of the 1.1 millimeter probe in diagnosing pulmonary nodules. So this was a prospective observational pilot study, an N of about 50 patients, and these were patients with nodules 3 millimeters or smaller, exclusively using the 1.1 probe along with a radial EBUS, virtual bronchoscopic navigation and fluoroscopy. Primary outcome here, again, diagnostic yield, and again, we're seeing that 90% range with most of these procedures getting 3 passes with the cryoprobe. And safety evidence here, so no pneumothoraces. They did see a pretty high rate of moderate bleeding, 26% requiring balloon tamponade. But I'll just point out in this figure an interesting analysis that really showed most bang for your buck being that first cryoprobe pass, right? 84% yield on that first one with diminishing returns with each pass. Though they also kind of analyzed your cumulative overall diagnostic yield does increase with multiple passes, but just realizing that that first pass is really the key. So another interesting facet of the study, and I think a potential real advantage with this 1.1 millimeter probe, our diagnostic yield did not change in relation to the radial EBUS view that you get during procedure. No matter concentric, eccentric, or adjacent, the diagnostic yield was the same across those EBUS views. And I'll just mention of the 50 procedures, 5 of them were non-diagnostic, and 3 of those patients did go on to receive malignant diagnoses via second procedures. Okay, so we'll finish up our review for pulmonary nodules. This was a nice narrative review published within the last year, looking at the handful of kind of smaller studies that have been published over the years. And across the board, we're seeing reported diagnostic yields in the 75 to 90% range. And there seems to be a particular diagnostic advantage in those nodules that are less than 2 centimeters with the ultra-thin 1.1 millimeter cryoprobe. And we also get the benefit of being able to access these historically more difficult to reach segments, right? Thinking the apical segments of the upper lobes. With the older cryoprobes, the bigger they are, the more stiff they are, and making those tight turns can be difficult. So really getting that added advantage. And then there's also a signal of increased yield in ground glass lesions specifically, and this is kind of intuitive, larger sample pieces, able to discern architecture and atypical cells more easily. So all of this being incredibly promising and has led to the Frostbite 2 trial, which has, I believe, recently or close to completing enrollment. So this will be our first randomized controlled trial looking at the difference between cryoprobe, the 1.1 millimeter cryoprobe and forceps, randomized in a 1-to-1 fashion, and including 500 subjects across a number of U.S. academic centers, and looking specifically at yield in these kind of 3 main pulmonary disease processes: diffuse lung disease, transplant, and pulmonary nodules, with our primary outcome being diagnostic yield. So anxiously awaiting the results of this to kind of further inform our practices with cryoprobe going forward. So with that, I think I will turn it over to Chris.
Great, excellent job, Jamie. I'd just like to point out that Jamie did a night shift last night and did a much better job and is way more put together than I would have been in that situation, so well done. So yeah, I'm going to take a couple more minutes to talk about mediastinal cryobiopsy, and then we'll get to why you were all here to hear the experts talk about how they use this. So just a little bit of background on, kind of the history of mediastinal lymph node biopsy. Really didn't come around till the 50s, and prior to that, cervical mediastinoscopy was kind of the standard of care, and really largely was up until the late 90s, early 2000s, when linear EBUS kind of stole the show and took over the lion's share of mediastinal staging. And I think dovetailing off of that, in 2016, and then also a plethora of studies that have come out since then showing the importance of targeted treatment. So really our job as diagnosticians is to try to provide an adequate tissue sample for our pathology colleagues to be able to interpret, and then also have enough left over for next generation sequencing and DNA profiling to really improve outcomes. And then, as Jamie mentioned, with the 1.1 millimeter cryoprobe, we were able now, since that's been introduced in 2020, able to use that a little more safely and effectively to get after both peripheral lesions and into the mediastinum. So is there really a problem here? And, is there a role to fill? So I think this was a nice study that was done by Sheehan and colleagues from Wake Forest, and they looked at how they were doing. This is with needle aspiration via EBUS to see, how good are we at detecting next generation sequencing. So you can see the percentages there in the graph on the right. For NGS, there were only about 58% sufficient. So there were a couple of things that did improve sufficiency. It was, the more aspirations you took at a target, the bigger the size of the lymph node. And then NGS efficiency, you really needed to take at least 3 needle aspirations, although, I think that's pretty widely universally practiced at this point. And then the other question we always get is with, EBUS and lymphoma, how good are we at this? This is a little bit of an older study now at this point, but EBUS was able to, establish a diagnosis in about 84% of patients. It's a little bit harder with this because you're trying to, from a pathologic standpoint, I'm sure we'll probably get into this later, because you need a lot of tissue in order to really subtype some of these lymphomas. So, I think in this case, there probably is a role for getting larger sample sizes. So how do we do this? And obviously we've already talked about this, but we need to freeze the tissue with our cryoprobe. So this was a study done by Dr. Herth and some of his colleagues, and we'll probably chat more about this later. And this is really the only study I'm going to touch on because we want to jump into the panel discussion. But it looked at cryobiopsy for the diagnosis of mediastinal lesions. It was randomized, so there were 180 patients, both at thorax clinic and then in a couple of hospitals in China, and they enrolled patients with mediastinal lesions that were greater than a centimeter, and excluded the typical exclusion criteria. We weren't able to get an EBUS or if there were cysts or abscess. And then the order, what was randomized was FNA and cryobiopsy, the order that they were performed. So half the patients went into the TBNA first, half the patients went into the cryobiopsy first. Good retention. There were only 2 patients lost to follow-up, and then the pathologists were blinded to the mode of the biopsy. So overall, TBNA against cryobiopsy for the diagnostic yield was better for cryobiopsy. It was about 80% for TBNA and about 92% for cryobiopsy. In common tumors, you can see they performed pretty similarly, and so that included adenocarcinoma, squamous cell carcinoma, non-small cell, not otherwise specified, and then small cell. So for common tumors, we're pretty good with EBUS TBNA. However, when we look at uncommon tumors, cryobiopsy really shined here. And it was a significant difference. So the diagnostic yield for the uncommon tumors was 91.7% versus 25%, and that did achieve statistical significance. You can see there what was classified. And then I think the big point here is with the lymphomas. It was able to establish a diagnosis in 7 out of 8, or 87.5% of the patients. So, and then the other area where the cryobiopsy really shined was also benign disease. So sarcoidosis, tuberculosis, and then pneumoconiosis, in the benign disease category, it really shines. So so this study kind of shows us that with our common tumors, like, we're pretty good at diagnosing those just with the needle. However, what about in our atypical stuff for things when we're, not necessarily suspecting non-small cell lung cancer? The other thing to note in this study was that cryobiopsy was sufficient for next generation sequencing or molecular testing at a higher percentage, 93 versus 73%. And what about safety? So the bleeding risk was the same in both. It was obviously very safe in terms of that. And then there was only 1 pneumothorax in each group, and then the pneumomediastinum occurred only once across all of these patients who had received both of these. So 1 out of nearly 200 patients. So pretty safe, and there were no incidents of mediastinitis as well. So one slide on technique, because I'm sure we're going to have our experts weigh in on this. I think there's a few different ways of doing this. By and large, you're probably going to do a TBNA first. You're going to get into the lymph node and create that tract. Needle size is always a question that comes up. My practice is just to use our typical 21 or 22 gauge needle to make that tract. And then I'll have Rose weigh in and see what the diagnosis is. If they're telling me, yeah, you got adequate cellularity, this looks great with the needle, then I won't always necessarily go on to the cryobiopsy. But let's say I'm not getting adequate cellularity, or I'm suspecting one of those disorders that is uncommon or a benign disease, then I'll consider using it. As far as getting the 1.1 millimeter cryoprobe into that channel, There's a couple different ways of doing it. Dr. Herth published on this, and there's some great videos online that I'm sure he can talk about. But he uses an electrocautery knife to make a little incision and then puts the probe in. Personally, I just put it through the needle tract, and generally speaking, you can get it in there fairly simply. I believe Dr. Maldonado would probably talk about this, but he uses a breath hold to kind of help him pop into it. My initial freeze is 2 seconds, although in the study that I quoted, they used 7 seconds. And these pictures here show the samples from that study, and those are just massive in comparison to kind of the TBNA. So more to come on this. And then I think importantly, and this study is being run out of Vanderbilt, but Frostbite 3, which is going to be an RCT where in non-small cell lung cancer, where we're looking at NGS deficiency. So you're going to pop into the node, get a confirmation that you do have non-small cell lung cancer, and then you're going to be randomized either to just TBNA or cryobiopsy. So that's open, enrolling, and we're looking forward to the results from that. All right, so enough from me. So let's jump into our panel discussion. So Jeff, do you want to kind of lead it off with the first question?
Yeah, sure. Chris and Jamie, those were both great talks. So for everybody out there, any questions, please go ahead, put them in the chat, and we'll get them answered for you. But I do have some box questions. So Dr. Jager, can I start with you, please? So we all have a boss. We all work for somebody, right? In interventional pulmonology, we often work as part of a multidisciplinary team, and our job is to really serve and do the best that we can to give our pathologists, our thoracic oncologists, our lung transplant colleagues the best specimens that we actually can, so you guys can do the most with what you have, and we can take care of the most amount of patients in the most optimal fashion. So I guess my question to you is fairly generic. I'm sure Dr. Kapp and Wahidi are sending down cryobiopsies to you, not infrequently. But what are you seeing as far as differences in terms of quality of sample, adequacy for molecular testing, and other diagnostic capabilities when you're looking at cryobiopsy specimens? And you can compare that to forceps, FNAs, surgical lung biopsy specimens. What's your general gestalt?
Yeah, so I guess in general, with cryobiopsy, the advantages come down to quality of the tissue and the quantity of the tissue. So a pathologist will never say no to more tissue. So just that these samples from cryobiopsy, they are larger. They tend to be a lot larger. So you're addressing that inherent limitation of small biopsies by getting more sample and also increasing the amount of lesional tissue with this. And then with quality, you have preserved architecture with the cryobiopsy. So especially in like these complex cases where maybe like, for example, like a really well-diff adenocarcinoma where the nuclei are really bland and can be really difficult to suss out, having that architecture can really clinch that diagnosis. Seeing it in its natural form, it really helps make a confident diagnosis. The other thing we see preservation of like the cellular structure, and with this, it helps with you can like see the cells, so then you can better work up the cells with immunohistochemistry and other things. We see less crush artifact and less hemorrhage with the cryobiopsy. So again, that also adds into better visualization. So better interpretation histologically, and we can interpret immunohistochemical stains and other ancillary studies. And this tissue it is well preserved for molecular testing. So overall, it has a lot of advantages from a pathology point of view.
Yeah. Okay. Great. Thanks so much. And maybe I'm just going to dovetail that, but we have a couple questions in the chat, which we'll get to. And I just wanted to expand maybe a little bit on the lung transplant side of things, and maybe Dr. Budev, if you could chime in as well. So we're actually doing frequently more and more cryobiopsies in the lung transplant population using our 1.1 millimeter probe. A lot of that had to do with problems in the past with forceps. We were getting a lot of inadequate results. We're getting bronchial walls. We're not getting enough specimens. We're getting a lot of these AX calls. And something that I had never really thought about before is like, I don't know if I ever really saw like a B rejection called from like forceps biopsies. That could have just been something local here. But I'm noticing, and I'm actually looking at the data from across multiple centers as part of the Frostbite 2 trial. And one of the things that I'm starting to notice, and we'll be able to publish on this, is that we're picking up on B rejection a whole lot more frequently than we were before. And I think a lot of that has to do with the architecture that we're getting. You're not really seeing those terminal bronchioles that you're seeing with forceps due to the crush artifact. So I guess my question to you is one of two things. Is one, have you seen that trend too? And maybe to Dr. Budev as well. Is there something to this? Have we been missing lymphocytic bronchiolitis in the past at a higher incidence than we maybe thought we were? And then also to Dr. Budev as well, really, do you think, what's your take on cryobiopsy? Is this something that's ready to be rolled out for lung transplant patients, or is this really something that belongs in the research arena for right now?
Lucy, I'll let you start.
So yeah, it's a great question. I think just because of that quality of the tissue that we're getting, you get more expanded lung fields and you're able to visualize these cells with less crush artifact. So I think it wasn't being missed necessarily. It was just the quality of the tissue from the forceps biopsy. So I think having that better visualization is going to lead to a better improved diagnosis and ability to make that diagnosis.
Thanks, Jeff. I'll start off with your last question first. Is there a role for cryobiopsy for lung transplant patients? I absolutely think there is. You, Dr. Rowell and Lucy have shared with you a tremendous amount of information and overview about the benefits of cryobiopsy and lung transplant, highlighting the superior quality of the specimens, the higher capture of bronchioles, as Lucy just mentioned, a lower rate of non-diagnostic samples with less crush artifact, as Lucy again just mentioned, and overall with a reduction of need for more specimens. This translates into more safety or higher safety for our patients. But more than that, let's talk about what's out there in the literature. I think Dr. Rowell shared with you the Lu meta-analysis that was just published recently in one of the journals, and it showed an increased diagnostic rate for CLAD and chronic rejection, which we all know, and especially in the transplant field, when you're using forceps, the yield of finding a C grade is only about 18%. We'll get to the B grade in a moment. So clinicians, therefore, we rely on spirometry, and that's the way we're now diagnosing CLAD. And to be frankly honest with you, maybe this horse is already out of the barn if you're just looking at spirometry, and already you're seeing changes that are happening in the lung parenchyma and the small airways, and that you're not picking that up because you had forceps biopsies that didn't have good sampling. Now, another thing, and taking this one step further, I think Dr. Rowell mentioned this as well, that CLAD is the foremost limiting factor to long-term survival in lung transplantation. So the early detection of CLAD is of great importance for possible interventions and to mitigate this pathology or syndrome further. And there was a recent publication that came out just actually last month in the Blue Journal from Jamie Todd on behalf of the Clinical Transplant Organ Trials. This is called the CTOT 20 trial. And this CTOT trial actually showed that certain pathological or histopathological patterns, such as acute rejection, acute lung injury, organizing pneumonia, have actually contributed and have the greatest independent information about probable or definitive CLAD risk markers. So histopathology is now playing even a greater role in our development and understanding of our patients having CLAD. And the next CTOT trials that are actually going to be opening this fall, hopefully in the next few weeks, CTOT 45, is going to be looking strictly at histopathology as a possible trigger for a pharmacological intervention to try to prohibit loss of lung function and development of further CLAD. So never more has it been an opportune time to actually have great samples on pathology so that we can get better readings. Now, coming back to the question of the B grading, we've seen this, it's very sporadic, it's very spotty with forceps biopsies. Having that B grading and on a larger sample for pathologists to actually call a B grading is of utmost value because the B grading actually does need therapy. It's controversial at some centers, but it could be a risk factor again for chronic rejection. I hope that answered your questions.
Yeah, it really did perfectly. Yeah, thanks so much. So yeah, maybe it is something. So we had just been doing our cryobiopsies on lung transplant patients really in the research realm, and it's only been in the past couple months, to tell you the truth, that we're now starting to do it more routinely clinically as well. And so part of that is really getting our transplant pulmonologists trained up as well and how to do the procedure as well. So I think that's kind of like the next step here for widespread adoption. Thank you. So I'm going to hop over to some of the questions that have started to come in through the chat. So the first one, maybe we can focus on mediastinal cryobiopsy. That seems to be something that's been the most recent hot topic that's been going on there. And the first question I asked was how many specimens should we be taking? This same question comes up frequently across board. They're talking about peripheral cryobiopsy for lung transplant, for lung nodules, for diffuse lung disease, or mediastinal cryo. So maybe I'll ask Dr. Herth to chime in, and maybe if you could answer the bigger question is, as far as just the technical aspects of the procedure, there's so many variables and different ways of actually doing it. Chris alluded to maybe a couple different modifications on the approach. But what's your approach? Meaning, like, could you go through maybe like what kind of airway you're using, which probe you're using? Are you doing en bloc pulls or through the working channel? How are you creating your hole? Are you using a needle first, or are you using rows to decide which patients you're going to be doing mediastinal cryobiopsy on, or is it all that you're using it on? If you could just share some insights. I know I just asked like 10 questions, but the gist of it is basically, what's your procedural approach?
Yeah, Jeff, so I will take the remaining 22 minutes.
Right.
First of all, starting with the indication. So when we have a patient where we have a high suspicion for lung cancer, nodule, smoke, lymph nodes. So we're doing the EBUS for the staging, and this is what we're doing with the needle. Published multiple times. For staging, the needle material is enough. But when we have patients where we have to do the diagnostics also via the lymph nodes, no robotic system available for whatever reason, then we also just turning that we're doing the diagnostics with the medicinal cryobiopsy, because Lucy already mentioned that the pathologist wants tissue. Tissue is the issue, and when you give them more, they are more happy, and we want to keep the pathologists happy, so we take a lot of material out, and we're using for diagnosing lung cancer via the lymph nodes the cryo. And all other diseases, when we have the suspicious for lymphoma, for uncommon diseases, we using the cryo as well. And as published in the various trials, you can reach at least every lymph node. You can put the cryoprobe in every lymph node you can see with the EBUScope. So that means EBUS first, TBNA needle in, rows. And if you get a diagnosis, then it's done. But to be honest, lymphoma in rows, and also therefore for clarification, rows only means rapid on-site evaluation. It's not a rapid on-site diagnosis. So you get the information, you get adequate material. And I think to decide on the cytology that you have adequate material for the lymphoma subtyping, I'm not a pathologist, but Lucy can answer that better. That might be tough. So therefore, rows first, and then as published, we using the electron knife to make that little incision. We believing that's easier. After having at least that little red stitch in the airways where we put the needle through, we putting the knife through, making the incision, probe in, And then in the trials, we did 4 probes. Nowadays, it's a little bit, I think this is also, you all are experts. You take the first material out and then you see the size of the tissue. Yeah. When it's too small, then you increase the freezing time. Maybe you take then 5 samples. When you see you have a big proportional material, then you would say, okay, 2 pieces, I'm happy. So in the protocol, we have protocol lines which telling us take 4 biopsies, but in daily doing, I look to the material and then I adapt my freezing time and I adapt my numbers of sample based on what I get out.
Yeah. That makes total sense. I think that's probably most of our approach as well, as starting with needle. And if you have your answer, hey, you have your answer, right? You don't need to go any further. And then it's kind of just an on-the-fly assessment really from there. So I agree. It's hard to say, put your finger down on what number of biopsies that you actually really need to be taken. So next question was really about contraindications for mediastinal cryo. Maybe if I could have Dr. Maldonado, if you don't mind chiming in, maybe you could share with us your approach and how you kind of tackle how you select your patients as well. And then I think specifically the question, which is actually a great one, is, you have a lymph node there and we very commonly see big vessels that are kind of coursing right through it there. Is that something that you would shy away from, or would you still feel comfortable going after that? Or thank you.
Big vessel and cryo, yeah, I would think twice. It's always a good idea. I very grateful for the presentation. That was super helpful. And I also think Jamie did a great job being up all night. So thank you for that. So I'll just say that when it comes to mediastinal cryobiopsy, I mean, we don't do it all the time. I mean, we have a randomized trial right now. So all our procedures that are in that context. So we get eligibility criteria for that, which is high suspicion of malignant lymph node. And if that's the case, patient will be randomized after Rose to continued cell block with conventional TBNA versus cryobiopsy. The data is really interesting. So I think the Joseph Chow meta-analysis from 2022 was mentioned. This was the largest meta-analysis on the utility of EBUS-TBNA for next-gen sequencing. And the success rate of conventional TBNA was anywhere from 50% to 99%. And so whenever you see a widespread like this, you have to wonder what's causing it. Clearly, this is not terrible bronchoscopies versus amazing bronchoscopies. Probably has to do with the way we define the diagnostic outcome. And so we looked at that, and it turns out a lot of these studies consider successful NGS when the actual sample is sent for NGS. And that's not really the denominator, because a lot of these samples are looked at, they're diagnostic from a histologic standpoint or cytologic standpoint, but not sufficient for next-gen sequencing. And if you don't include this in the denominator, you're going to get skewed, biased overestimates of successful NGS. So in terms of, how many passes for EBUS-TBNA, we got a great study by the Wake Forest group that was also mentioned. That's Christina Bellinger's group. Three passes, 3 EBUS-TBNA passes or more, you're at 67% sufficiency for NGS in their cohort. Less than 3 passes, you're about 36, 37%, something like that. How that translates into cryobiopsy, no idea. We're doing the study, so I'm not even sure it's going to help in terms of successful NGS. And that's why we need to do the study. The other point is what I'm really excited about is the momentum for comparative studies in IP. I mean, this is tremendous what you've done, at Hopkins, along with many other centers, to look at mini cryobiopsy in the periphery of the lung versus forceps biopsy. That's really the only way to get answers, because I don't know what a diagnostic yield of 99% means. That may just mean that you're selecting patients that you're pretty darn sure you're going to get a diagnosis on. So the selection bias is a huge problem. And so in order to address these issues of patient selection and selection bias and outcome measured definitions, I think comparative studies are absolutely critical. So I'll finish by saying how we do it. I mean, like I said, we do it as part of a clinical trial. So that's 99% of the mini cryobiopsies of lymph nodes that we do. But if we get a patient who already had an EBUS, obviously, and it was diagnostic, but NGS was insufficient, then we'll go straight to mini cryo. If we suspect lymphoma, we'll go straight to mini cryo. And aside from that, it's really kind of dealer's choice, really.
Yeah. Great. Thanks so much, Fabien. Really appreciate that. So you kind of hit on a couple points there that I just want to maybe explore a little bit more, maybe from the pathologic side. And Frostbite 3, I know is kind of maybe more focusing on our non-small cell carcinomas or carcinoma in general. But one of the biggest hurdles or maybe roles that we may see on cryobiopsy is actually in lymphoma, to tell you the truth. And I wonder, Dr. Jager, if you could maybe explore a little bit about what are the challenges with lymphoma? Why is it so difficult to make a needle diagnosis of lymphoma? Why is structure, and maybe not why is structure so important? We know why it is, but to what extent? Meaning, like, do you need to have an excisional biopsy to make a firm diagnosis, or can our spot biopsies with cryo be sufficient enough? Along those same lines, from while I'm beating you up here on questions, is one of the things that I've noticed coming up with cryobiopsy is the pathology's lab hesitancy to run flow cytometry off of the cryo specimens. I wonder if you could comment to that as well.
Yeah, so I think, so to address the first question, actually your last question about the flow cytometry, I don't think there's enough studies out there that have been conducted to let us know if we should be doing it. But if you think about it, for flow cytometry, we need viable tissue to be able to run it. So with the freezing technique, it actually does keep the tissue viable. So it would make sense that flow cytometry should be able to be performed. There was a small study of 4 patients where they did perform flow cytometry in those cases, but I think that needs to be more widely explored. As far as the diagnosis of lymphoma in these cases, architecture is really important. For a lot of it, the immunostains and the immunoprofile is not enough. They need to, for the hematopathologists, have to see the architecture too. And so tissue is the issue. So the more we get, the better it is to make that diagnosis. A good example is with Hodgkin lymphoma, the tumor cells are actually very rare and the rest is all reactive lymphocytes. So with these, you have to be able to catch those tumor cells, make sure they're well preserved so you can do your immunostains and identify them appropriately. So if they're crushed, like with our forceps biopsy, it can, even if they are there, if they're crushed, the immunostains can't be interpreted properly. So it would miss that diagnosis. So that preservation of architecture and the preservation of that cellular structure is really important for those the lymphoma cases.
Great. So we have about 10 minutes left. And so basically what I'd like to highlight now, maybe chat about now with Dr. Wahidi and Dr. Yarmus, maybe be more of if you could theorize a little bit about the business side of things, meaning cryoprobes are more expensive than forceps biopsies are. I think the quoted rate for a cryoprobe, a disposable cryoprobe, is probably in the $400 range compared to the less than $100 range for the forceps biopsies. And a lot of us, as adoption is being widespread, are going to have to go to our various, value analysis committees and make the argument as to why we think that we should be doing cryobiopsies. So, wondering if you could take a swing at what your thoughts are, and maybe some strategies that people may be able to adopt when they're needing to go to their value analysis folks or their administrative folks and ask for these new tools and devices.
Sure, I can start, Jeff. Thank you. So, yes, you're right. There's no reimbursement right now for cryobiopsy. There's no code for it. You can't really put the code for cryotherapy because that was meant for ablation of tissue, not for biopsy. So if you put it, your coders will not submit it. So basically, we're eating the cost of the $400 and also our labor. But I think to me is this could be worth it because if you save the patient's repeated procedure, a mediastinoscopy, a surgical resection to get more tissue, to get the diagnosis, or perhaps to get more tissue for NGS if your EBIS is not adequate, I think this is worth it. If we prove the value, clearly we're doing all the research. We saw the study from Dr. Herth and others. I still think the jury is a little bit out on the value of cryoprobe in lymph nodes, but I think we need to learn more about it. And if we really prove the value, I think it would be worth the cost and the investment because of the downstream and the avoidance of additional procedures.
So I'll follow that, agree with Dr. Wahidi, and just add to the comments I think that Dr. Maldonado was bringing up on the research efforts and how substantial that's been and how this links to that, right? So cost efficacy and cost efficiency studies are difficult at a baseline. They're extremely difficult if you have a poor data outcome set. Now that we have progressed much to, Jeff and Chris and much of the group's here's efforts for Frostbite 2, we're going to have a large randomized controlled trial to start to look at peripheral cryobiopsy and the outcomes there. And then, phase 2 of that should be cost to prove that, not only is this diagnostically better for patients and all the downstream flow, but that incremental cost increase, which is minor in the context of most health system projections and finance, but it's still there and it's certainly impactful globally. So showing that those hard clinical outcomes can obviously quickly offset cost concerns.
So, Jeff, I'll jump in. I think we have a couple of questions that have kind of focused on this, but for peripheral bronchoscopy, and I'll open this to maybe Felix and then some of our other expert interventional pulmonologists. Do we think this is ready for widespread adoption by non-interventional pulmonologists? We have the safety data. Do we think this is ready?
Well, maybe when I can start, we published that data with the help of Lony, and the safety signal was similar to the transbronchial lung biopsies. And as we're really having more and more data that the molecular signaling of the tumor is dependent for the patient, and now having the neoadjuvant immuno trials, we want to know more than only non-small cell lung cancer and small cell lung cancer. Therefore, tissue is the issue. And it depends a little bit, to be honest, how good is your pathologist. When you have an expert like Lucy, who is doing a lot of lung tissue analysis, then maybe you can send her a couple of cells and she can do everything. But most of the pathologists are not dedicated lung pathologists. They're doing everything. And depending to the volume, you should debate with your pathologist, with the pathologist, what he prefers and what he needs. But I think based on the safety data and all the trials we have seen before in the intro presentation, I don't have any problems to promote it as a technique you can use.
Lony, Momen.
I agree, but I would just caution of the technique used. I know some of us do the electrocardiography knife. I think that should be reserved to people who are skilled or interventional pulmonologists. Electrocardiography knife is simple, but it can go awry. So I think if non-interventional pulmonologists want to do these techniques, I would recommend the needle, which is safe, and that would be a better approach in my mind.
I'll just add that this is new, right? These techniques are developing, they're new. We don't understand all of it. And we also don't fully understand the true optimization of the technique. So these types of efforts and the studies that are ongoing, if we can show benefit, then, and in parallel, we should be looking at, device innovation to improve on that, reduce cost, right? reduce the need for multiple different tools to gain access, and ideally cater the procedure, appropriately. So that's coming as well. And I think that'll help adjudicate some of the, cost and burden concerns in terms of procedural flow.
I think, just to add that quickly, I think you should be able to handle the complication independent which technology you're using. When you're not able to handle the possible complication, don't do it. So therefore, it can happen also in other procedures.
I was going to add that one thing we don't want to do is to repeat what we've done with large cryobiopsies for ILD. So this was introduced in 2009, became the messiah of ILD. Everybody swore by it. Lots of people jumped on the bandwagon. And before you knew it, we had lots of cherry-picked observational single center series that showed marvelous diagnostic yields and zero complication, until the paper started coming out showing and anecdotes that we heard from the community suggesting that there were a bunch of catastrophes that were not reported, and that led to a number of guidelines. I think we got more guidelines for cryobiopsy in ILD than for any other topic in IP, and that should tell you something. And the studies actually came later on. So we're thankfully changing the process. Other societies like the SAGES Society in GI have guidelines for introduction of new technology that are, perhaps not rigorously implemented, but at least they have some guidance. We should have the same. We should be cautious. We should go through the different steps of inquiry to make sure we get solid data to recommend using these procedures. I would say that at the present time, if you're going to do it, the safest way to do it is always to pull the specimen through the working channel, so you get your scope down there that can do something if something happens. And I echo what Momen said. I mean, if you're starting to make cuts in the airway and pull like a centimeter large lesion, you'd better be ready to handle any complication that may come with that we don't know yet about. And you'd better be a trained interventional pulmonologist and have a good justification for doing it from a diagnostic standpoint.
Great, thank you. There were a couple of questions, Lucy. We have like a minute left. There was a question about standardizing pathology and then the importance of sending these specimens to a center that does a lot of this. I guess in a few quick words for people, is there a standardization, and do you recommend sending some of these to centers that do more volume?
As far as standardization goes, Chris, I think you're really familiar with how we do it here. We all, we follow that standardization, whether it's cytology or surge path signing it out. We always kind of follow that same, what is included, the components that are included. So I think this is more and more the goal for nationwide. And then as far as sending these to like a larger center that has more experience, I think because the tissue it's actually, Jamie showed the really nice pictures of the tissue. It's more pleasing to look at. So I think most pathologists would be pretty comfortable with it if they have good experience with lung pathology. So I think that's the things to consider there.
Great. Well, we're just about at the hour. Jeff, I'll hand it over to you to kind of wrap up.
Yeah. I just want to thank everybody, all of our panelists and everybody that talked and everybody that came and kind of participated here. We had a great session. Thanks for your time. And with that, I'll give everybody 1 minute back of their day. Thanks, everybody.
Thank you
Thanks,
all.
everybody.
Thanks.
Thank you, guys.